What is important for us as surgeons is to obtain a complete R0 resection. So every patient has to be discussed within a multidisciplinary team, and our final aim for any surgery we perform for lung cancer is to obtain a complete resection. So this is for the surgeon a bit of personalized medicine, but every patient is discussed within an MDT, and then the right strategy is proposed to the patient. Okay. Thank you very much for the invitation to talk about the perspective of the thoracic surgeon in the multidisciplinary management of lung cancer. These are my disclosures. So what is important for us as surgeons is to obtain a complete R0 resection. So we look at the technical resectability, so the T descriptor. We look at the oncological resectability, the N and the M descriptors, but also at the functional operability of the patient. So every patient has to be discussed within a multidisciplinary team, and our final aim for any surgery we perform for lung cancer is to obtain a complete resection, for which precise criteria have been already published in 2005 by the IASLC. So I'd like to draw your attention to the fact that at least 6 nodal stations have to be removed and 3 from the mediastinum, including the subcarinal station 7. When not enough lymph nodes have been removed, this is called uncertain resection, which should be avoided as it decreases your overall survival by 20 months. So as Dr. Hirsch already mentioned, we now have the choice between the adjuvant approaches. So we start with surgery followed by chemotherapy and immunotherapy or targeted therapies. We have the neoadjuvant approach. We start with immunotherapy or targeted therapy with or without chemotherapy, followed by surgery. And then we have the perioperative approach, where in fact surgery is sandwiched between immunotherapy with chemotherapy and adjuvant immunotherapy after the operation. So in Europe, we usually follow the ESMO guidelines for stage 1 and stage 2-3 disease. I broke them up to make it a bit more clear. So when you have preoperative evaluation MDT discussion for patients with stage 1 who are medical operable, surgery is preferred as initial treatment, and you can discuss whether you perform a sublobar resection for tumors smaller than 2 centimeters without positive lymph nodes, so with negative lymph nodes, or lobectomy. When you have an R0 resection, for smaller tumors, we go for surveillance. For larger tumors, which have an EGFR exon 19 deletion or an L858R mutation, osimertinib is given for 3 years, as you already heard. It's a bit more complicated when you have medical inoperable patients. Then usually we'll start with SBRT, followed by surveillance. In case of local progression, salvage surgery can be considered, but you can ask when it was initially medically operable, whether the patient will become operable after SBRT and local progression. Then we move to stage 2 and 3 disease. As already mentioned by Dr. Hirsch, it's important to have EGFR, ALK nowadays, and PD-L1 testing. So for those patients with wild type, who are on the left side, chemotherapy and immune checkpoint inhibitors ineligible. So we start with surgery. In case of R0 resection and patient becomes chemotherapy eligible, then cisplatin-based chemotherapy is given. For those patients who are PD-L1 positive, atezolizumab for 1 year is considered, or pembrolizumab. For those who are negative, pembrolizumab for 1 year is given. For those patients on the right side who are chemotherapy and immune checkpoint inhibitors eligible, they start with an adjuvant chemotherapy with immune checkpoint inhibitors, followed by surgery. And then, as you heard, there's some discussion which patients will benefit from postoperative, so adjuvant immunotherapy. For those patients with resectable stage 2 and 3 non-small cell lung cancer, who have an EGFR mutation or ALK rearrangement, we start with surgery up front. In case of R0 resection, you have an exon 19 deletion EGFR or point mutation 21. For those patients who are chemotherapy ineligible, down on the left side, osimertinib is given for 3 years. When you are chemotherapy eligible, cisplatin-based chemotherapy followed by osimertinib for 3 years. For those patients with an ALK rearrangement, you can discuss whether you should start with chemotherapy initially, followed by alectinib, as already been discussed by Dr. Hirsch. So there's a lot of discussion going on about definition. So stage 3 non-small cell lung cancer and resectability. The EORTC just published a consensual definition of what constitutes stage 3 non-small cell lung cancer, and the paper just has been published by Dr. Dingemans in the Lancet Respiratory Medicine in 26. So in summary, we look at whether those patients on the right side are unresectable, in the middle whether they are potentially resectable, and on the left side whether they are resectable or not. And most of the patients with N2 single disease constitute resectable disease, in contrast to the new N2B classification in the TNM9 classification, that most of these patients will have unresectable or in some cases potentially resectable disease, as for example N2 multi-level involvement. So we also looked at those patients with T4 and 0A1 tumors. T4 by separate nodules or by size are considered to be resectable, and by infiltration of major structures, some are potentially resectable and some are unresectable, as you can see on the slide. For example, invasion of the myocardium, of the trachea above the carina, the esophagus, or the spinal cord are usually considered to be unresectable. So this is for the surgeon a bit of personalized medicine, but every patient is discussed within an MDT, and then the right strategy is proposed to the patient. And these were my slides, so I'll stop the sharing and I'm ready to answer any questions you might have.
Thank you very much, Paul. That was elegant. I have just one question. Are we all in agreement with resectability and lymph node examination? Do we know exactly, is there a harmonization in guidelines? How many lymph nodes should be studied, and is there a clear harmonization in the definitions of resectability?
No, there is not for the moment. That's the reason that the EORTC published those criteria, but it's a bit work in progress. Those are not definitive, so they are meant to guide new strategies, to also guide new studies that, as you know, resectability and unresectable, as in the Pacific trial, has not been clearly defined. And when you look at those papers, for example, the Pacific did not give a precise definition of unresectable disease, and all the neoadjuvant and the perioperative strategies, when you look at the paper, they don't give a precise definition of what constitutes resectable disease. So that's something that has been discussed individually, but the purpose of the EORTC criteria was give a kind of harmonization for further discussion. It's not set in stone, but it's for further discussion. And regarding the lymph node dissection, we know that the more lymph nodes you remove, the better your staging will become. And that's the reason that IASLC already proposed in 2005 a general definition of during lung cancer surgery for invasive lung cancers, at least that are larger than 2 centimeters, that you should remove 6 nodal stations, 3 and 1 and 3 and 2 nodes, of which 1 should be the subcarinal station. And when you do not do that, we know from an analysis of the IASLC database, in case you have positive lymph nodes and you have removed less than 6 lymph nodes, your overall survival will decrease by 20 months. So that's a very huge figure that should also be considered when you analyze the neoadjuvant and the perioperative trials. So when the surgeon does not do the right operation, not the right staging intraoperatively, survival could already be decreased, and that could be a problem when analyzing those data.